Okay, good evening. It is now 8 o'clock and I have to start now because there is a group B coming on and we cannot waste the time. Otherwise, they will have to finish at 11 o'clock. We have 1 hour and 15 minutes and this is what I'm going to do with you. So I'm going to share screen. So what I'm going to do is share the screen with you all so that we can see slideshow. Okay. What we are going to do today are a few things. We are going to do feedback on your assignment. We are also going to do case discussion. And then I would like you all to tell me about feedback on the tutorial session, whether you want it any other way. Okay, some general comments about your assignment. I distinctly remembered telling you all that you have to write your name, your IC, place of practice, town and state, so that I will roughly, when I read your assignment, I would know where you are from, whether you are GP setting or whether you are KK setting, and whether it's a big KK or a small KK. Okay. But I still see some of you still do not write down your name, your place of practice, which is quite essential. Good number of you have done it. Thank you for doing that. The other thing that I would like to comment is that I find that overall, the quality of the assignments have improved very, very much. I hardly see any grammar mistakes, spelling mistakes, punctuation mistakes, and all that. So all those things are gone. However, there may be still some poor organization of presentation, like throwing out whole chunks of things, some of which may or may not be needed. Although I specifically mentioned that no more than 3 references, some people still give more than 3. In fact, I did not manage to read through all your assignments, but the few assignments I read through, there was a person who gave 4 references. But on looking closely, I find that two of the references mentioned the same thing. So it was 3 references, but those are things that will say that you didn't read through your work properly or you didn't present as good a paper as you can. And this, remember, these assignments are given marks, and the marks are also used for your final exam. By the way, can you all hear me or not? Because now I
Can,
can't.
Prof.
Okay, good. If
Yes,
you
Prof.
can't hear me, please interrupt and say you can't hear me. Okay. The other thing that I find is you have to read your clinical scenario and answer to the question. Okay. If you don't read an answer to your question, you will lose marks. Okay. I will show you some examples of what I mean. Although quite a few of you have already started using your own words, some have not used their own words and still copy and paste some of the things. But it's not as bad as last time when we had whole paper all copy and paste. I suspect that some of you may be using AI to help with the dictation and with the grammar and all that, which is okay because it makes for a better reading. Okay. And spelling mistakes and all that, you all have corrected that, which is okay. But not copying whole chunks of whole sentences, whole paragraph. Okay, let's dive straight away. Okay, and Vancouver style, I did remember saying that I want you all to write not only in Vancouver style, but to say when was it assessed, and also give the website address so that I know that it was a recent access, and I know if I want to read about it, I can access it just like this, can click on it and you will bring me to the particular channel. Okay. This also I can click on it, it will bring me to the particular website. Okay. Assignment 1 is your own case. So I will not comment on it because all of you have your own cases. But I noticed quite a lot of you all wrote on Bell's palsy. From the few assignments I've read, I've not read all. Okay, for assignment 2, I must say congratulations again because you all did well, very well. Most of you know all the answers, but miss out maybe one or two. Okay. I only have 2 questions, but I wanted you all to answer in your own words and to provide not more than 3 most relevant references. I find that some of the references you all gave were not the most recent, something like 2002, long ago one, which may not be so relevant now. So try to get the most relevant and also what is pertinent to the question. So the first assignment was a 21-year-old primate with no significant personal or family history. But again, I see people when they write the answer, they say they want to take history again, to ask for history of thyroid disease, diabetes, and all that. But it's written that no significant personal or family history. Okay. She presents at 10 weeks of gestation with nausea and vomiting for the past 2 weeks. That means the nausea and vomiting started 8 weeks ago. At 8 weeks of gestation. Okay, very early at 8 weeks of gestation. And she's still having the nausea and vomiting. But in addition, she has lethargy, palpitations, heat intolerance, and weight loss. You do expect to have some weight loss if you are vomiting. And during pregnancy, there may be some tachycardia, but if palpitations, heat intolerance, you may have to think of something else. And on examination, she's also anxious looking. She has coated tongue and dry oral mucosa, but her eyes were not sunken, which means she has some degree of dehydration. I would put it as moderate dehydration, coated tongue already, but not sunken eyes, so it is not severe dehydration. She has fine tremors, but if you are thinking of thyroid, you have to look for exophthalmos, goiter, which she doesn't have, and she has no lymphadenopathy. Okay, she has lost 5 kilos, which is significant. Okay, 5 kilos, which is 10% of her weight. SpO2 is okay. There's no fever. BP is slightly lowish, but this can happen in pregnancy and also with dehydration. Pulse rate is definitely increased, but there is no atrial fibrillation. The other findings are all not significant. I think I've lost one slide on her T4 and TSH. Okay, I think I've lost one slide. Okay, anyway, she has a raised T4 and low TSH. Okay, so the question I asked was, write in full the most likely diagnosis for the patient, give reasons for your answer, and the most likely diagnosis, because we are writing in full, we have to say this is a primary gravida with gestational transient thyrotoxicosis with twin pregnancy and moderate dehydration due to hyperemesis gravidarum. Some people wanted to quantify the severity of the hyperemesis gravidarum using modified pregnancy-induced quantification of emesis, and that is all right. Okay. In fact, there is a CPG, Malaysian CPG by Ministry of Health on hyperemesis gravidarum. And I asked also for the reasons why you come to GTT and why you make the diagnosis of GTT. And the reasons will be because she has signs and symptoms of hyperthyroidism. Okay. But her, and raise, including raised FT4 and low TSH. But the absence of goiter and the absence of exophthalmos and absence of family history, most likely she's not Graves. The absence of a goiter indicate that she is not toxic adenoma or multinodular goiter. The absence of any lymph nodes also said that she's not having any malignant condition. The T3 is supposed to be only normal or slightly elevated in GTT compared to Graves' disease, where it is significantly elevated. So T4 is more elevated than T3, and the free T3-T4 ratio may be decreased. In this particular patient, the GTT and hyperemesis gravidarum are risk factors because, twin pregnancy is a risk factor for both GTT and hyperemesis gravidarum. Okay, so the second question was, she refuses admission. What is your holistic plan of management for this patient in primary care? I already said she refuses hospital admission. Okay. Some of you still said to admit her. So that is not reading your question properly. If we tell you that she refuses already, you go along that line, refuses, and how you manage. And some manage like in hospital, but this is for management in primary care. Initially, you would have to explain that what she's having is a GTT and not a real thyrotoxicosis problem, okay? And this GTT will be spontaneously recovered by the second trimester, 14 to 18 weeks of gestation, when the HCG declines. GTT occurs in the first trimester and only up to the first half of the pregnancy. It will not have any effects on maternal or fetal outcome, okay? But if it is very severe, it can cause preterm labor, preeclampsia, and low birth weight. The principle of treatment is not to give anti-thyroid drugs because of the short duration of the disease and the spontaneous resolution of GTT. We do not recommend anti-thyroid drugs, okay? Anti-thyroid drugs can cross the placental barrier and cause fetal hypothyroidism and birth defects, especially if given early in pregnancy. But although we said that don't give anti-thyroid drugs, in severe GTT, sometimes we do have to give anti-thyroid drugs, okay, where the risk outweighs the benefit. And some patients, they start with GTT, but they can go into hyperthyroidism, okay? One of the ways that you can manage GTT is usually supportive, okay? Because she also has hyperemesis gravidarum, you need to give antiemetics. And for the GTT, you can give beta blockers and IV fluids as appropriate. Although IV metoclopramide can be given, it is usually used as second line, okay, because of the risk of extrapyramidal effects. And some of you rightly mentioned that you will give Phenergan, promethazine, IV or IM as first line. And some of you in GP practice, once the vomiting is controlled, they will give another combined drug that combine a vitamin with a anti-emetic drug, okay? And that is totally acceptable too. That's why I need to know where you're from. You can give beta blockers because you want to control the tachycardia, the tremors, the heat intolerance. And the beta blockers, you try to use the lowest therapeutic dose and the shortest required duration to minimize potential risk of fetal growth restriction. Because if you give too high a dose, you can theoretically cause a fetal growth restriction. So I think a dose of 40 milligram BD for a short period of time using propranolol is totally acceptable. Okay. And the fluid should be IV normal saline. Okay. Rapid administration of normal saline can result in too rapid a correction in sodium levels and may give rise to central pontine myelinolysis, which is irreversible. I noticed reading an answer that says, give 2 liters of normal saline in 2 hours. I think that is too excessive, okay? Too excessive and can cause central pontine myelinolysis, okay? So be very careful. Probably you give 1 pint, which is 500 ml. 1 liter is 1000 ml. And then the next 2 hours, you can give another 500 ml. Of course, always monitoring the patient. Once your injection goes in already for anti-emesis, the patient may not vomit and you can start giving her oral fluids. Okay. Dextrose infusions are not appropriate because it can cause Wernicke's encephalopathy in a woman who is thiamine deficient. Okay. The fluid replacement can be tailored to ketonuria and the electrolyte imbalance and discontinued once you are normalized and a normal diet has resumed. So after giving the injection for anti-emesis and the patient does not feel so nauseated and can drink, it's better to give them a oral diet because you are not admitting the patient. And if you are treating the patient as an outpatient, you don't want to overtreat and cause on-time myelinolysis or overhydration. Okay, most of the time it will correct itself once she's on a normal diet. You can use ORS also. Okay. For this kind of cases, you need to do serial ultrasound and Doppler scan performed monthly to monitor fetal biometry. And you should also involve the O&G specialist as well as the endocrine specialist for shared monitoring of this case. And it is advisable also to give 2 to 4 weekly thyroid function tests, which you have to repeat. Okay. Any questions about that before we go on to cases for discussion? Any questions?
No, boss.
Okay, if you have no questions, let me just check my time. Okay, let's go on to cases for discussion. You can read the case. I'll give you 2 minutes to read the case and try to answer the question. Write down in your, your notebook or whatever. You have to try to attempt the question so that when we discuss, you will know how right or how wrong you are. Okay. Let me see whether I can see you all so that I can ask you all some questions. Okay. Unless I make this big. When I make this big, I can't. Okay. When I make this big, I can't see my work already. Let me call somebody. Muhammad Amal.
Yes, boss.
What condition is he having?
Possibly meningitis secondary to otitis media.
You think it's meningitis? Okay, it's a possibility. Okay. But he was well during the day, He only started later on. Yeah, there's a possibility. Any other possibilities? How about you, Maha?
So it can be severe infection like abscess
Where's the abscess?
from the ear, severe ear infection.
From the ear and goes to from the ear.
Yeah.
Okay. Any other people with any other different answers? Lee Siu Leng. Lee Siu Leng, are you there? Okay, somebody said history of trauma, no history of trauma. Okay. Let me go back again to the case. Okay. So, what he has is a cerebral abscess. Because if he has got meningitis, there will be other signs of meningism. Okay. This cerebral abscess is because just now we said that he has recurrent ear infection, and that is a clue. The recurrent ear infection and the abscess is a brain abscess. Okay. So he has headaches. Okay, if abscess in the ear discharge, no, usually ears, no abscess, but the infection can go to the brain. Okay. And what is against the meningitis is still neurologically intact. Okay. Doesn't have the meningism and all that. Okay. So for these type of cases where you suspect he has a brain abscess because of recurrent ear infection or even recurrent sinusitis, and they complain of fever, headache, and seizures, fits, you can refer straight away to the hospital. The hospital, of course, must have a neurologist for further management. So the answer will be refer to a hospital where to be seen by neurologists. Okay. And the investigation to confirm it will be a CT brain scan. Okay. Next question. Can you all read the thing? Is the thing anything blocking you all from reading?
No.
No, okay. So this is quite easy, but it's a little bit tricky. Okay, anybody want to shout out the answers? Anybody want to shout out the answers?
Could it be Prof?
Yeah, Subhashini, yeah.
Yeah. Based on the presentation, could it be Cushing's disease with the central obesity, with the bilateral adrenal atrophy?
No. That's why I say it's a little bit tricky.
I see.
Okay, good guess, but it's not. Okay, anybody else? When I open and see your names, I can't see my PowerPoint. I think next time should have two computer lah. Okay, can see. Anybody else want to try?
I think it's exogenous steroid use, Prof.
Very good. That is the correct answer. Who was that?
Anusia Chandra.
Okay. That is correct. Now, how do I get back to my now I have to get back to my slides. Okay. See how to get back to my slides. I have to make this small. Let me see. Okay. I have to make this small. How do I make? Okay, layout. No, it's not this. Now I have to get back to my slide. Height meeting. Okay, height meeting. Let me see. Okay, I should height meeting. Okay. And make this small. Okay. Okay. You are right that it is exogenous steroid use. And the clue lies in adrenal atrophy. It is a case where a doctor or maybe the patient himself is taking corticosteroid. So once you take corticosteroid, you have a negative feedback to the pituitary to say stop or reduce your ACTH from the pituitary gland. Okay, and when this occurs, there is no more ACTH to drive the adrenal. So the adrenal go into atrophy. Okay, so the answer will be exogenous steroid use. If it's Cushing's disease, you get bilateral adrenal hypertrophy. And if it is ectopic ACTH production, you also will get adrenal hypertrophy. Okay. And adrenal malignancy, such as adenoma in one gland, would suppress ACTH production, causing atrophy in the normal adrenal gland, while the gland with the tumor will be either normal or bigger. And of course, it cannot be E, the 21 hydroxylase deficiency, because that caused an increase in ACTH production from the pituitary, leading to adrenal hyperplasia. So the correct answer is exogenous steroid use. Okay, let's go on to the next one. Okay, read the thing. This is a woman with migraine with aura. By the way, classical migraine means migraine with aura. Most of the time, we don't have migraine with aura. So there's nothing wrong with the blood pressure. Her lipid is normal, but she has a stroke and she's too young to have a stroke, 30 years old. There is no accelerometer's plug and echo does not reveal any thrombus or anything to cause a stroke. So what is the most likely abnormality? Anybody want to answer? I don't want to call names because when I go over to the other side, I cannot see, I will not be able to see my slides again. Anybody want to try? How about you, Ahmad? Nabila? Nurul, Amira? What is the most likely diagnosis? Wei Jian Cheng?
Prof, may I try?
Sure. What's your name?
Shahira.
Okay. What is your answer?
I think it's tricuspid incompetence.
Sorry, no. This is a disease. Yeah,
Prof, may I try?
sure. Name, please.
Navarhani binti Abdullah.
Okay,
I
good.
think because this is young stroke. Stroke in young patient could be PFO.
Yes, the answer is PFO. Okay, the answer is PFO, patent foramen ovale, because there is an association between PFO and migraine with aura, the classical migraine. So people with classical migraine, you have to be a bit more careful. OCP is totally contraindicated and they have a higher chance of getting stroke. Due to the abnormal blood flow flow of blood. PFO can result in decreased blood oxygen saturation and decreased oxygen to the brain. So this can also trigger migraine. So remember, if you got patients with classical migraine, you might want to refer them for an echo to see that they have patent foramen ovale or not. Okay, next one. Oops, given you the answer. Okay, anybody want to try? Well, this is how meningitis presents: fever, vomiting, headache, and they will have examination rashes, non-blenching petechial rash, and they would have stiff neck. Okay,
Can I try for?
sure. Name, please.
NeuroEndo.
Okay, good.
Yeah,
What
I
is your
think
answer?
it is A.
Yes, this is a case of meningococcal meningitis. Okay, that's where you get the non-blenching petechial rash, and the answer will be intravenous ceftriaxone because this is classical. Okay, so only ceftriaxone or cefotaxime will work. Okay, the rest will not work. Okay. And blood culture will take too long. IV cefalexin is not enough. Lumbar puncture is contraindicated because we don't know whether he's got increased intracranial pressure. Fundoscopy is not, the patient will not allow you to do fundoscopy also because he will be so irritated and it doesn't help you to diagnose. So the best management will be to give the injection as soon as fast as possible. They actually in UK and all that, you are supposed to give the antibiotics right in your GP clinic in UK. In Malaysia, I don't know whether you all got IV ceftriaxone. Okay, but if that will be the treatment. Okay, the next one. This is also a little bit complicated. Anybody want to try to answer? Anybody want to try to answer?
Can I try for?
Sure. Just say your name and also
Uh,
what is the answer.
I'm Aisha Jalil. The answer
Say
is
again.
E. I'm Aisha Jalil. The answer
Uh-huh.
is E.
What is
The
your answer?
E. Intravenous saline.
Okay. The answer, you are correct. Okay, you are correct. Your voice is pretty soft. Let's see. All these symptoms and the examination and the x-ray shows that this patient possibly has a multiple myeloma. Okay, so it's a multiple myeloma and he is dehydrated. It's written here that he's confused, dehydrated, and so the treatment is to give IV saline. Okay. He is dehydrated due to the hypercalcemia. It's written there his calcium is raised. The multiple myeloma the clue lies in the lytic lesions on X-ray. He is dehydrated as seen from reduced skin turgor, sunken eyes. So this one is severe dehydration. Okay. The hypercalcemia is manifested by dehydration, depression, bone and abdominal pain. Okay, probably due to renal stones. And you need to stabilize him by giving him intravenous saline. Okay, to replace the fluid loss and to stabilize him. Okay. And giving intravenous saline will reduce his hypercalcemia. Okay, next one. This one should be an easy one. Anybody want to try? You can just say your name and shout out the answer.
I'm Aisha again. Can I try?
Sure. Can you, I'm hearing very soft. Can you speak louder? Let me see whether I can make it louder. No, I can't now. Audio, yeah. Can you speak louder?
Okay. Is it clear now?
Yeah, barely. What is your answer?
I think I want to answer for venous insufficiency, but Professor already showed the answer.
Yeah, I put out the answer already. Sorry. It's decubitus ulcer. What do you want to answer?
I want to answer as venous insufficiency, but I think it's wrong lah.
Which one? I can't hear. I'm trying to make the sound louder for me to hear, but I can't get back to getting the sound louder for me to hear. Okay. Let me see the video. Audio setting. Let me see. Let me see audio setting. Just now I thought I made it high already. Oh, it doesn't allow me. It doesn't allow me to increase the audio. Okay, it doesn't allow me. Okay, since I've already given you the answer is decubitus ulcer because the patient is unable to move her left leg and there's decreased perfusion and ischemia and breakdown of tissues. A venous ulcer usually affect the middle malleolus area, and together with it, you're looking at varicose veins or previous deep venous thrombosis, and you will get shallow irregular ulcers with surrounding skin changes. The skin will be in dark color. Diabetes ulcer usually at the base of the first metatarsal head due to neuropathy, causing decreased sensation and pressure ulcers. So the neuropathy will be symmetrical and bilateral. That means both sides. Okay. She has risk factors for arterial insufficiency, but such ulcers are typically punched out and occur on the heel or in between the toes. And the patient also have reduced or absent leg pulses and claudication. There is no evidence to suggest bacterial infection. Okay, this one. One of the ways, if you don't know the answers to a MCQ, you can see which is not the correct answer and you delete it off so that in the end you will be left with one or two answers, possible answers. Then you just choose which is the best answer.
Prof, is it a B?
Say the full thing.
B, Cauda equina syndrome?
Yes, correct. It's Cauda equina. Okay. So here you have inability to open bowels. There's decreased rectal tone with saddle anesthesia and prolapse. This into the cauda equina, causing compression of the sacral nerve. This one is a medical emergency or an orthopedic emergency lah, because it is very important that you diagnose it. That's why if somebody come with backache, you have to ask them about the bowel and the urination, okay? And you also have to do the examination of rectal tone and also look for saddle anesthesia, okay? In such a case, cauda equina, if you don't treat it immediately, the patient will permanently be fecal and urinary incontinence. It won't come back to normal. So it's very, very important. It cannot be the other things because you can read through the answers, okay? You can read through why it cannot be the other things. Okay. This one, anybody want to shout out the answer?
Hypothyroidism.
Yep. The answer is hypothyroidism, okay? And the hypothyroidism is usually due to Hashimoto thyroiditis or due to postpartum thyroiditis, okay? If it's postpartum thyroiditis, you get confusion and is characterized by low mood, anhedonia, and anergia. So something like, a little bit something like postpartum depression. Even, sorry, this postpartum depression is the one that is accompanied by confusion and low mood and anhedonia. Postpartum depression can be quite dangerous because sometimes they will kill their babies, okay? Or sometimes they will kill themselves. It cannot be malignancy, okay? So the most likely answer is hypothyroidism. Okay, this one. A woman who is growing fatter and has got some facial flushing and also high BP and has got bruising on her arm. What is the most appropriate initial investigation?
Low dose dexamethasone test.
Any answers?
Okay. Low
Hello?
dose dexamethasone. Hello. How
Yep.
about A? Low dose
E.
dexamethasone.
No, the answer is E, urinary free cortisol management. And you can see there is an algorithm. If you suspect that she has Cushing syndrome, this will be the way you do. 24-hour urinary free cortisol. Okay. Then you see whether it's increased. It has to be increased 3 to 4 times the upper limit of normal for you to say 100% that it's Cushing syndrome. If it is not increased so much, then it's equivocal, then you have to do other tests. Okay. So it has to increase 3 to 4 times. And sometimes we have to do more than one sample to be sure. If you are going for admission, you can give the midnight dexamethasone, because that one you have to give injection at night and then morning do. But as an outpatient, the only one that is useful is 24-hour urine for cortisol. Okay, the next one. A man who is growing fatter, sweats easily, has got coarse features, feeling very tired, and has got weakness. What is the most likely diagnosis? Anybody? Any answers from anybody? Hello? Okay, I think we have to
Hypothyroidism.
say again.
Hypothyroidism.
No, this is acromegaly. Okay, acromegaly, and I have to go faster because otherwise we cannot finish. And the reason is because he has got acromegaly patients will grow bigger. It's due to a tumor lah. And sometimes they usually present first with changes in appearance, which will take a long time to occur. They become coarser features, uglier. The late features are visual defects and headache. Okay, they can also have sleep apnea. If you look at the hands and feet, it will be very huge, and they can have hirsutism, prominent and coarse facial features, carpal tunnel syndrome, hypertension, diabetes, and heart failure. So the treatment is, the test to confirm is IGF-1, insulin-like growth factor 1. Okay. If you look at the endocrine test, there are 2 publications by Malaysian Endocrine, Metabolic and Endocrine Society. Okay, they call it MEMS. And MEMS has got this book where they put out the how to investigate for endocrine disease, and they also have the practical guide to endocrine disease, and they also have the 14 acromegaly consensus. Okay, how to diagnose acromegaly. So if you have time, go and read this. Okay, and you should read this because it will be quite useful. Okay, this one. This one, all of you should get it right. What is the answer? This one is actually Graves' disease. Okay, in Graves' disease, you not only have exophthalmos. The exophthalmos can be so bad that you have double vision. Okay, and you also have finger clubbing and raised painless lesions on the front of the shins. So the answer is Graves' disease. Graves' disease. Okay. Okay. This one. So a patient with polyuria and polydipsia. But no glycosuria on dipsticks. What is the diagnosis?
Is it diabetes insipidus?
Yet, no. This is probably psychogenic diabetes. So the water deprivation test will be the best one for this patient. Okay. Psychogenic polydipsia. But for water deprivation test, you have to admit to the hospital. Okay. In diabetes insipidus, the serum osmolality will be elevated with no compensatory or concentration of urine osmolality. Okay. So this one, Okay, this one is psychogenic diabetes. Psychogenic polydipsia. Okay, this one. Patient with hypogonadism, undescended testes, low plasma testosterone, LH and FSH, and a karyotype is a male, 46XY. During neurological examination, he cannot smell very well. So this is common syndrome, okay? In common syndrome, it's associated with difficulty with smelling. Okay, I have no time to go through common syndrome, but you all can read about it. Okay, and this one, anything with an acute, painful, and tender neck with signs and symptoms of hyperthyroidism.
C. Thyroiditis.
You have to think of thyroiditis. Okay, so in this case, is decreased thyroiditis. Okay, again, you have to go and read out about this because these are not common things. Okay, thyroiditis due to viral infection. I don't have time to go through all this with you, but you can read about it and read what is plumber disease, what is all the other things. Okay, this one. So you have someone with postural hypotension and with hyperpigmentation. Okay. So in this case, the answer is Addison's disease. Okay, they have hyperpigmentation, postural hypotension. And the hyperpigmentation could be in the mouth, could be in the palms of the hands. Okay. So read about it also. It's not common and you probably can miss it, but it is something that is important because it can lead to death. Okay. Usually in Malaysia, you have to think of TB causing Addison disease. Okay, this one. So this one is also difficult. The answer is motor neuron disease, where you have a combination of upper and lower motor neuron lesions. Okay, so read about motor neuron disease. Okay, couldn't be the other things. So read about motor neuron disease where you have both upper and lower motor neuron physical examination. Okay, what are these lesions seen on this woman's thighs? This is the pre-tibial myxedema that is seen in Graves' disease. I've never seen one myself, but this is how it would look like. Okay, so Graves' disease, you have exophthalmos, you have the acropathy, and also the pre-tibial myxedema. Okay, Okay, this one. What diagnosis do you think of? What is the most likely diagnosis from anyone?
Intracranial bleed tu, ICB.
Subdural hematoma. Okay, because it will occur from days to months depending on the degree and rapidity of the bleeding, and usually following a fall or blow to the head. So symptoms include headaches, increasing drowsiness, and confusion. Okay. This kind of case, you have to refer immediately to the hospital for admission. It must be a hospital, tertiary hospital, where you have a neurosurgeon, preferably, because you need to evacuate the hemorrhage. Okay, this one is something that you seldom see. So you look at her, the first picture, she looks very normal, except that she likes to tilt her face to one side. When you force her face to tilt to the other side, what do you see in her eyes? What do you see in her eyes when you force? Here is normal, but you force her head to look the other side, the opposite side. You see this. You see this eye going up. So what do you, anybody has a right answer? Okay, I'll give you the answer. This is fourth nerve palsy, trochlear nerve palsy, fourth cranial nerve palsy. Remember the mnemonic, SO4, SO4, superior oblique 4, LR6. The rest are all third nerve palsy, okay? Only two nerve. Superior oblique, the fourth nerve, and lateral rectus, the sixth nerve. So other things are all third nerve. Okay, so this is the fourth nerve palsy, which you don't hear often. Lateral rectus, you all know lah, it's very easy. One eye cannot see. When you ask him to turn right and then turn left, one eye cannot move. But this is very rare. But it's something that we may have missed it, And it's very important because it is the congenital one. You have to detect it early and refer early so that correction can be done. So the superior oblique muscle, SO4 muscle, the main job is to move the eye downwards. But when there is a palsy, it cannot move the eye downwards. That's why the eye moves upwards. And to compensate for this girl has to tilt her head this way so that it looks normal. That's why she always like that. And you sometimes think, oh, the child is very cute like that. But it is because of a problem with the eye. So next time when you are looking at children, please look for this, okay? So the treatment will be surgery as early as 6 months because otherwise you get amblyopia. If the child doesn't know how to do the movements to check, she can have amblyopia because she only use one eye to see. You can have it as an adult also. As an adult, it's usually due to trauma. Okay, so it's congenital or trauma. Okay, any questions so far? Any questions from you all? If no questions, then I will show you some movement disorder. and you have to identify the abnormal movement. What do you think is this gate? I think in the interest of time, I just show you the
The
answer.
next gait is the spastic diplegic gait. In this particular gait, both lower extremities are affected, and the lower extremities are affected more than the upper extremities. So the posture, the position of this particular gait is there's flexion of the hips, flexion of the knees, and the feet or the ankles are extended and internally rotated. And there's also tight adductors, so there's adduction at the knees. So it is a swinging gait with both sides of both lower extremities. You can hear a different pattern than the hemiparetic gait. But this is not all. The upper extremities are also involved. Again, not as much as the hemiparetic gait, but for the upper extremities, the extremity is carried in a low guard or mid guard position. And you don't have the normal associated movements in the upper extremity. So this would be the type of posture and type of position that one would see for the spastic diplegic.
Okay, showing you the next gate.
This gait is a myopathic gait. With myopathies, usually we have weakness in the pelvic girdle region. And as I walk, if I can't stabilize my pelvis, then what ends up happening is that for the weight-bearing leg, I'm trying to stabilize the hip, and I'm coming off with the other, the pelvis will then dip or drop towards the non-bearing extremity. Now, if I continue in this attitude, I'll fall. In order to compensate for that, I'm going to shift my weight, and I'm going to try to put it over the weight-bearing leg. And so I'm going to actually swing the body towards weight-bearing leg and trying to get hypermordotic and lock back over the hip that's stabilizing or is actually supporting the weight. So what will this happen is that there will be a waddle as the pelvis will actually drop, come back up, drop on the other side, and go back and forth instead of being nice and perpendicular to where it should be to the leg. So again, this is what it would look like if I'm going to walk. As I take this step, the pelvis will drop, I'll shift this way, and then as I come through, I'll shift this way, the pelvis will drop on the opposite side, and there will be a waddle. I'm in a hyperlordotic position, trying to maintain my balance.
Okay, the next gate. This one is the easiest lah. Don't have to show you all. Anybody can shout out the answer for this gate?
A shuffling gait.
Yep. It's Parkinsonism. Huh? It's a gate for Parkinsonism. Okay.
This gait is the gait that is a hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait in which the patient will have a posture in which you'll be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then again, having difficulty starting in the marche petit pas.
Okay, next gate. Anybody can tell me what gate is this?
Cesarean gate.
Say again. This is a cerebellar gate.
The last gate that I'm going to demonstrate is the ataxic gate. The ataxic gate, the patient has difficulty narrowing the station, maintaining balance. So typically they'll have a wide stance, trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is an anterior posterior type of tremor at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic, I then try to walk tandem, then I'm going to have difficulty walking.
Okay, that's all. Let's get back to you all. Any questions from you all or not? Any questions from you all? We are
Sorry,
supposed to
Prof, what's
finish
the
at
first
9:15.
gate? Was the
Yeah?
first gate waddling gate?
Say again. The first gate was a waddling gate.
Okay, thank you.
Any other things that you all want to say or ask? I have a fracture on my hand. Okay, so I have problem writing in the comments for your assignment. I was trying to do dictation, but I don't know whether it works. Whatever it is, so I may not write a lot. I may not put comments so much in what I've for your assignments, but that's why today I'm giving you what could be the correct answer and all that. Okay. And what are some of the problems or mistakes that you all make? Okay. If is there any other questions that you want to ask?
Sorry, Prof. Just asking regarding the just now the gestational transient toxicosis. What is the best guideline we can use for that?
The what? Say again.
The
GTT.
best guideline
The
for
best.
GTT
The best what?
guideline itu, Prof.
Huh? What? The best what? Guideline. Okay. What you can do is you can look there. We have the Malaysian CPG on thyroid. Okay. You can look at that. You can also look at the hyperemesis CPG. You can also look at some newer articles on gestational GTT lah, thyrotoxicosis in pregnancy. You can look nice, I don't mind, whatever lah, update or whatever that you all have. But don't go and look at old ones lah. Okay. So there are quite a lot of places where you can get some recent update on it. And it's quite common now. So please look out for it, and it will also come out in exams. Okay. Any other questions?
Good evening, Doctor. Good evening, Prof. I would like to ask a question about the logbook. Is there any criteria do you need or format?
The what? Say again.
For the logbook.
What book?
Logbook. For our logbook.
I don't understand what
Logbook, Prof.
Oh, logbook. Is there any
format or criteria that we need to add on in our logbook for the learning point?
learning point will be something that you have learned and it won't be something that you learn from the case. Maybe it's something that you didn't know, but now you know, or it is something new about the case. But it won't be just giving titles and say complications of diabetes. It won't be just giving subtitles like that. And it has to pertain to the particular case. Like supposing a case show up something different, then you write about that case, that problem. Okay, so that is what is meant by learning issue.
Prof, sorry. Since this module is divided into endo and neuro, does it mean that our logbook should be 4 neuro cases and another 4 is
No,
for
not necessary. But it will be better for you to mix them up for your own learning sake.
Okay, thank you, Prof. Because we didn't see much for endocrine case as
Thyroid 100% you will see. I know their rest are not common. Thyroid 100% you will see.
Yeah,
And
because I just saw
among thyroid, you got different kind of cases, hyper, hypo, you got thyroid in pregnancy.
Okay, thank you, Prof.
Yeah, okay.
Okay.
Most important thing to remember, don't copy from people. Okay? And don't use the same case in different modules. Okay, then I have to stop share here. And I also have to stop because I will have to get ready for the next group. Okay, so I'm leaving you all.
Thank you, Prof.